Hello everyone. Okay, so we have started the preparation for Peads talks and we have already discussed the first 10 stations. The last station that we discussed was hypothyroidism. Now we will learn the counseling station. So, what are the common cases that are asked in the talks of Peads? The most common are asthma, breastfeeding, and how to manage the patient of birth asphyxia. These are the most common topics. So, we will start from asthma. Okay, we will just learn the basic method of counseling, how counseling is done in the talk station. So, first of all, what we have to do is to introduce ourselves, then we will ask the relation with the patient. If Ammi is present or Abu is present, then we will ask about her education and then told her language. Ask them what they know about the disease, then explain to them about the disease. If examiner asks that they listen about the treatment, that there is a drug treatment of asthma which cause short stature, diabetes mellitus or hypertension later in life. So which one will be your drug of choice? Or what is the drug which causes the hypertension, diabetes mellitus or short stature? So that drug is steroids. This is the most common point which is commonly asked in asthma. That's why it is discussed here. So steroids is that drug which causes short stature, diabetes mellitus or hypertension. Then told patient attendant that we give it by inhalation, not by mouth, so its adverse effect will be less. If we give it by mouth, then there will be more chances of adverse effect. Okay. If you want to study the case of asthma in detail, so in these pictures, the discussion of asthma is given in Urdu language, so you can give a read to it. Okay, the next important station is breastfeeding counseling. How we will counsel the breastfeeding? So, convincing for breastfeeding is given here in the Urdu language. The basic method will be that of like asthma, which we discussed already. So if you want to learn the breastfeeding, then you can read to this page. Okay, how we will counsel a patient of VSD, ventricular septal defect? First of all, we will introduce yourself. Don't say I am student, say I am doctor dash. Okay, ask attendant relation with patient, mother, grandmother and father. Ask about attendant education so that you explain the disease in their language. Ask attendant what you know about the disease. Explain disease to them. If defect is small, then assure the parents that it is a benign lesion and child should encourage to live a normal life. Told parents that it should be closed spontaneously by 1 year of life. If defect is large, then told parents about the treatment modalities. Medical treatment of ventricular septal defect is digoxin, diuretics, and after load reduction medication. If not responding to medical treatment, then surgery is next option before 2 years of age. Ask attendant, did you ask any question? And then say thanks in the end. Okay. Now next case is Erb's palsy. What is Erb palsy? It is the injury to upper nerve root, that is C5 and C6 during birth. Hand turned inward, that is prone, paresthesia. What are the causes? Shoulder dystocia, breech delivery, excessive pulling of shoulder, and direct injury. Which muscles are the affected muscles? Deltoid, loss of abduction. Supra and infraspinatus, loss of external rotation. Bicep and supinator, loss of supination. Vegetative posture. Okay, what are the reflexes? Absent motor reflex. Association is impaired sensation over the external surface of upper limb. What are the treatment options? Nerve transfer, partial intermittent immobilization in position opposite to the lesion, physiotherapy. Okay, what is the prognosis? If nerve root intact, full recovery will occur in more than 90% by 3 months. If no improvement in 3 months, consult neurosurgery for nerve grafting or neuroplasty. Okay, now come towards gene karyotyping. For trisomies, focus on chromosome 13, 18 and 21. 18, 21 and 13. Okay, so for karyotyping diagram given, focus on chromosome pair 13, 18, 21 and sex chromosomes. 13, 18, 21 all are trisomy. So they have 3 chromosomes instead of 2. When there are more than 2 chromosomes, that is 3, then there will be trisomy and some type of syndrome will be present. Now, if the defect is 13, then it is Pato syndrome. If it is 18, then it is Edward syndrome. And if it is 21, then it is Down syndrome. Sex chromosome, if one extra X, then it's Klinefelter, that is 47XXY. Both X's are large chromosome and Y is small chromosomes. If only one X only, no Y, there then it is Turner syndrome, that is 45X. You can see in this table that in the Klinefelter syndrome there will be 47XXY. So the stature will be tall and IQ level is less. Unique findings will be microgenitals and infertility. These are the common findings of Klinefelter syndrome. Now, if it is Turner syndrome, then it will be 45X. IQ will be normal and the unique finding will be web neck and coarctation of aorta in Turner syndrome. In Down syndrome, there is trisomy 21. Duodenal atresia or AV canal defect are unique findings. In Edward, there is trisomy 18, functional MR, severe MR, and profound mental retardation, mitral regurgitation, okay? And there will be profound mental retardation. What are the unique findings? There will be abnormal feet and fist. In Porter syndrome T13, there will be the same as that of Edward, and there will be holoprosencephaly cyclops. So these are the important features of these syndromes, and these are the more common syndrome, especially the Klinefelter, Turner, and Down syndrome. So you must remember these syndromes in the for the talks of Peads. This is Turner syndrome, only X chromosome, no Y chromosome is there. In trisomy 21, focus on chromosome 21, there are 3 instead of 2. This is 21, there are 3 instead of 2. Okay. Now, what is pedigree? Pedigree is how we will identify that it is autosomal or X-linked or dominant or recessive trait. So, if the simple trick is if the male is involved, then it is autosomal. If male is normal, then it is X-linked. If full affected, then it is dominant. And if carrier, then it is recessive. Okay? But you have to focus only on first 2 parents, first line. Okay? Now, the next station is how to examine the chest. If there is a command given on the talk station that examine the chest, then what you have to do? First of all, say greetings, then approach the patient from the right side, then introduce yourself. I am doctor, okay? Don't use the word student. Then take consent and properly expose the patient. Look for malnutrition and nature of voice, lip and tongue for central cyanosis. Look for flaring LNSI. Check for necessary muscle of respiration, chest indrawing, inspection, palpation, percussion, auscultation, position of trachea, and then say thank you. Okay. The next station is what is clavicle fracture and what are the causes. The causes are breech delivery and shoulder dystocia. What are the treatment options? Pinning the sleeve to the shirt and gentle handling until callus forms. Okay. If a command is given, examine the apex beat, then the steps will be same. First say greetings, then right side approach, then introduce yourself, then take consult, then properly expose the patient, then inspect the patient, then palpate, then auscultate. The heart rate in newborn is 120 to 160. You must remember this figure that the heart rate in neonates or newborn is 120 to 160. Say thanks, cover the patient. Okay. What are the anthropometric measurements? This is very important for the Peads OSCE. You must know that at what age, what is the normal weight, length, fontanelles, head circumference, and what are the important milestones of the baby at different ages. Where is it? Here is it. Okay. So, weight. You should remember the weight in kgs. For the first 12 months of baby, you should remember the figures. At birth, the weight is 3.5 kg normal, and at the first 4 months, 6.5 kg weight is normal. Next 4 months, it is 8 to 9 kg is normal, and beyond 1 year, for the calculation of normal age beyond 1 year, we have a formula that is age in year multiply by 2 plus 8. For example, if the age is 2 years, then 2 multiplied by 2 plus 8. So 2 into 2 is 4 and 8. So 8, 19, 11, 12. 12 kg is the normal weight for the baby of the age 2 years. Okay. You can also calculate it through this method. For the age of first 4 months, multiply by 0.75. For next 4 months, multiply by 0.50 and 0.25. The normal length at birth is 50 centimeter, at 6 months is 68 centimeter, at first year is 75 centimeter, at 2 years 87 centimeter, and after 2 years, this is the formula: age multiplied by 5 plus 80. So the age in centimeter, you must remember the age in centimeters. Head circumference at birth is 38 centimeter, and first 3 months increase 2 centimeter, in next 3 months 1 centimeter. Okay, the other figures are increasing after age, that is the weight increase with time, the length increase with time, but the head circumference, the increase in head circumference reduce with time. First, it reduced at the change of 2 centimeter, then 1 centimeter, and then 0.5 centimeter. Same goes for the teeth. The milky teeth start at 6th month and complete at 24th month. The permanent teeth is 32 in numbers, start at 6th years and completed at 22 years. Fontanel's total 6 है. At birth, 2 anterolateral, 2 posterolateral, anterior and posterior. Anterior and posterior are only palpable. Anterior 3.4 cm at birth, close at 18 months. Posterior is less than 0.5 cm at birth and close at 2nd month. Bulging, increase intracranial tension, CNS infection and hydrocephalus. Okay, the bulging fontanelles will be present in case of intracranial tension, CNS infection and hydrocephalus. Depressed will be in dehydration shocks. These are the important milestones. At 3rd month, the baby can head support. At 6th month, it can sit without support. At 12th month, he can walk or she can walk. At 16th month, running. At first year, set 3 words, and at 2 months, social smile. Okay. Length, mid-arm circumference, weight, BP, heart rate, pulse, respiratory rate, and temperature, and these are the important anthropometric measures. Okay. The next is NG tube. What are its uses? It is used for gastric wash, gastric decompression, aspiration of gastric contents after ingestion of toxic sub, administration of medication, feeding unconscious, and bowel irrigation. Confirmation of NG position by aspiration of gastric contents, by auscultation, and by radiography. Okay. X-rays etc. can be taken. By auscultation, we can palpate or auscultate through stat, and by aspiration of gastric content. What are the complications? Aspiration pneumonia can occur due to NG tube perforations, ruptures of varices, irrigation in conscious patients, and bleeding. What are the contraindications? It should not be used in case of kerosene poisoning, corrosive poisoning, or injured neck or spine. This is X-ray chest. What are the findings? This is left pleural effusion with trachea shift. This is trachea. This is the left side. This is the right side. So here we can see the effusion. So this is the left pleural effusion with trachea shifted. Trachea is shifted to this side. This is the posterior interior view. Okay. So what are the findings? There is opacification present, obscute costophrenic angle and diaphragm. These are costophrenic angles. Meniscus sign, shifting of mediastinum and trachea to opposite. Okay. What are the organisms that are responsible for pleural effusion? These are Staphylococcus aureus, H. influenza, Streptococcus pneumonia, Mycobacterium tuberculosis. What are the symptoms? Fever, dyspnea, respiratory distress, and chest pain. What are the treatment options? Treat the underlying cause and thoracocentesis with or without chest tube. Okay, the next topic is X-ray chest, that is bronchiolitis. What is bronchiolitis? Lower respiratory tract, microbiology, clinicals, complications and management. Clinicals occurs primarily in children, often preceded by 1 to 3 day fever, cough, respiratory distress. Dehydration, apnea, and spiration pneumonia are the complications. Okay, this is the X-ray of bronchiolitis, X-ray chest. What are the findings? Here is the hyperinflated lungs, lung field black. Okay, hyperinflated lungs are present. Increased translucency of lungs, increase in anterior posterior diameter, decreased bronchovascular markings, and diaphragm is low. What are the clinicals? Rhinitis, mild fever, dyspnea, cough, wheezy chest, and respiratory distress is present in case of bronchiolitis. What organisms are involved? Rhinovirus, parainfluenza virus, adenovirus. What are the differential diagnoses? Congestive cardiac failure, bronchial asthma, bronchopneumonia, pertussis, FP aspiration, and cystic fibrosis. What are the treatment options? Oxygen inhalation, propped up position, IV fluids, correct electrolytes, and respiratory acidosis, ribavirin, and antibiotics. Complications: pneumothorax may develop pneumonia, dehydration, respiratory acidosis, and respiratory failure. This is X-ray pneumonia of lobar pneumonia. This is X-ray chest posterior interior view showing opacity in lower lobe of left lung with obliterated CP angle lobar pneumonia. This is left side, this is right side, and this is PA view. Opacity in lower lobe of left lung with obliterate. This is the left lobe of lower lobe lung of left side, and here the opacification is present. So, what are the findings? Diffuse white opacities with no sharp border, air bronchogram, dark lines through white area, usually unilateral. What organisms are responsible? Strep pneumonia, Staph aureus, gram-negative E. coli, H. influenza, Klebsiella, and Pseudomonas. What are the complications? The local complications are pneumothorax, empyema, pleural effusion, and abscess, distant meningitis, septicemia, arthritis, and osteomyelitis. What are the treatment options? General, bed rest and good diet, oxygen inhalation, antipyretic, adequate fluid intake, and physiotherapy. What are the specific antibiotics? Strep pneumonia, benzylpenicillin, and erythromycin, Staph aureus first generation cephalosporin, and cloxacillin, H. influenza second, third generation cephalosporin, and for gram-negative third generation cephalosporin and chloramphenicol. The next case is miliary TB. What are the findings? Lung field filled with small tubercles, typically miliary shadow, uniform distribution. Miliary TB X-ray showing small tubercles spread throughout the lungs. These are the small tubercles that are spread throughout the lungs. So, in case of miliary TB, this will be the appearance. What is the treatment? Anti-TB therapy for 12 months, bed rest, nutritional diet, physiotherapy, and proper follow-up. What is the prevention? Primary BCG, vaccine, and secondary is isoniazid for 1 year. Okay, this is the diaphragmatic hernia. This is the X-ray of diaphragmatic hernia showing intestines in the thorax with mediastinal shift. What are the findings? Presence of intestine in chest in upright position. Here the intestines can be seen in the X-ray of chest. On X-ray of abdomen and chest, angiotubi in the chest. Angiotube is present in the chest, and there is mediastinal shift. What are the treatment options? Immediate NG section, nursing of a baby in supine position, breathing support, and surgery to repair the defect. What is osteopetrosis? Okay. This is osteopetrosis showing multiple healed fractures bone on bone appearance wide osteochondral junction, multiple bone repairs. Okay, well, how we will identify very wide spine? The spine will be very wide, old X-ray marble bone appearance will be there. What are the findings? Multiple healed fractures, weak and dense skeleton, bone in bone appearance, widened costochondral junctions. What is the inheritance pattern? It is autosomal recessive, infantile, poor prognosis. If it is autosomal dominant, then in adult and good prognosis. Okay, what are the treatment options? Most specific treatment is bone marrow transplant. Vitamin D can be given, gamma interferon therapy, steroids for bone resorption, erythropoietin for anemia. Okay, this is the micturating cystoerythrogram, fluoroscopy and contrast media with special form of X-ray. What are the uses? To find causes of repeated UTI, to look for injury to bladder and urethra, to find out vesicoureteric reflex, to find out cause of urinary incontinence. What are the risks? Irritation from catheter resulting in discomfort when urine after test, bladder spasm, allergic reaction to contrast dye. What are the indications? Suspected obstruction, bladder trauma and rupture. Contraindications: untreated, hypersensitive to contrast media, fever within 24 hours past. What are the grades of fever? There are 5 grades. First, second, third, fourth, and fifth reflex into ureter only. In second, there is collecting system without dilatation. In the third, there is reflex into collecting system with mild dilatation. In fourth, reflex into collecting system with moderate dilatation. In fifth, the gross dilatation and toxicity of ureter with gross dilatation of renal pelvis and calyces. 29 number is cardiomegaly X-ray. This is X-ray chest PAV. What are the findings? Increase in CT ratio. Prominent pulmonary vasculature is present in large cardiac cell hot. Double counter to right chest border and splank of carina. What are the causes? Congenital and acquired. Congenital VST, TOF, Eisenmenger syndrome, and Epstein anomaly. In acquired, there is rheumatic heart disease, hypertension, dilated cardiomyopathy, cold pulmonal, and severe anemia. What are the treatment options? In general, bed rest, semi-upright position, good daily caloric diet, salt restriction, fluid restriction, treat infection with antibiotics, oxygen therapy, vital monitoring, input-output record. What are the specific treatment options? Blood transfusions, diuretics, vasodilators, digoxins, and ionotropic drugs. Okay. The last station that we will discuss in this video is the whooping cough. What are the causes? Bordella pertussis, Bordella peripertussis, and droplets are routes of infections. Clinical, catarrhal phase, paroxysmal phase, and convulsant phase is present. The differential diagnoses are adenovirus infections, bronchial asthma, FB inhalation, pulmonary TB, mycoplasma pneumonia. What is the diagnosis? Absent fever, sore throat, tachypnea, and wheezes. Cough for 14 days or more with at least one paroxysm. PCR CBC leukocytosis with absolute lymphocytosis. What are the treatment options? Isolate for 5 days. Isolate for 5 days after starting antibiotics. Bed rest. Avoid triggers of cough. Care of feeding. Antibiotics, azithro, and clarithromycin. And DTaP vaccine for prevention. What are the complications? Otitis media, bronchopneumonia, latent TB, atelectasis, bronchiectasis, convulsions, and malnutrition can occur in case if the whooping cough is not treated on the time. Pertussis, also known as whooping cough, Bordetella pertussis is the main cause, and there are three phases: catarrhal phase, paroxysmal phase, and convulsant phase. Catarrhal phase lasts for 2 weeks, paroxysmal 2 to 3 months, and the convulsant for 1 to 2 weeks. And these are the major treatment options, that is erythromycin, azithromycin, and clarithromycin. Okay, so in our next video, we will discuss the iron deficiency anemia and the megaloblastic anemia and other bleeding disorders and all the other stations which are important for the toacs of Peads. Thank you.